is give you a little bit about the basic overview of ultrasound physics, but this session will specifically cover ultrasound physics in relation to lung. Image generation is a kind of a basic general aspect, but we need to kind of get a feel of the physiology behind how ultrasound waves interact with tissue. And once we understand how they interact with tissue, we're then going to talk about how the ultrasound waves actually interact with lung. Because when we look at lung, we're not really looking at structure, in particular beyond the level of the pleura. What we're looking at is artifact. An artifact is really, it's not tissue. It's really an amalgamation of how sound waves interact with the lung tissue to generate certain what I would call artifacts, which we then interpret by pattern recognition. Now, as a first, the most basic principle of kind of ultrasound is that the ultrasound wave is generated, and it's usually more than 20,000 megahertz, but generated from the probe, it will move towards tissue, it will interact with tissue. And as you can see over here with my pointer, that a majority of ultrasound waves, depending on the density of tissue that interacts with, will reflect back. If the ultrasound probe is at completely perpendicular, the majority of the waves will reflect back and you'll get very good images. But if it's slightly oblique, you can see how the waves reflect. So some waves will come back, but a large number of waves will reflect away. And this is very relevant to lung, and I'll explain why. But naturally, some waves will then be transmitted because they reflect back. Some of the waves that reflect back move in a direction that's slightly separate to the actual waves coming back to the probe. And really, at the margins, the images may not be as clear as for waves that are incident in a kind of a perpendicular fashion, return perpendicular. That will give you the clearest, best elements of the image. The portion of the wave that reflects away will probably reflect uh, an image area that's not so clear. And then we have images which are generated because of what happens when the sound waves enter the tissue and penetrate deeper. And there's an element of interaction that we'll talk about. I mean, refraction is one aspect, but sound waves also get absorbed, they lose energy and they attenuate and they scatter. And all of that interacts with that tissue to kind of give us an overview of what that tissue looks like. Now, as I said, a sound wave basically is generated with a frequency over 20,000. It's beyond the level of hearing. So naturally, those kind of waves can't be heard by us. But they are generated by piezoelectric crystals, which are basically present within the probe. And in order to get these piezoelectric crystals to generate sound waves by actually vibrating, you have to give them electrical current. So any ultrasound machine connected to an electricity source has basically got uh, the ability to be able to transduce that electricity into these piezoelectric crystals, which are kind of kept to the probe, which is attached to the machine. That those kind of vibrations basically through the application of electrical current generate these sound waves. These sound waves go interact with tissue, bounce back, come back to the ultrasound machine, and eventually these ultrasound waves are converted into an image that we actually see. What does that really look like? So a few things about the probe. So when you look at the probe, probes are designed in a very scientific way. So you've got the piezoelectric element at the front, and I'm just going to annotate for you so that you guys can see. Uh, so you've kind of got the piezoelectric crystals kept here, and this is what basically vibrates and generates sound waves with electricity, which then interacts with tissue. But what's important is that the piezoelectric crystals and their vibrations to generate sound waves need to be directed in one direction. So what you've got is an acoustic insulator at the back, this entire backing up material. And it basically means that it insulates and prevents the sound waves from going backwards so that they move only in one direction. We have also got a kind of a matching layer, which kind of is present just in front of the piezoelectric element. And again, it's very important because what it helps do is direct those sound waves into a very focused area. It also has elements in it which allow us to change certain properties, like the focus, like the ability to kind of increase the intensity, the amplitude, alter the frequency of the actual probe. So you kind of have that all incorporated into this particular probe that you see with the element of a protective casing, and that's very important. So the protective casing basically protects these piezoelectric crystals. Now just remember, if you drop this probe and it hits the floor, bang, then you're going to run into real trouble. Not only that, there's a real risk in these circumstances that you'll end up damaging the piezoelectric crystals. Now, if you damage this element here, then what is going to happen is you're going to have differential sound waves being produced at the margins, but no sound waves being produced in the middle. And that's going to result in dropout in your image, which is going to give you very poor quality images. So it's very important that you take a good care whilst you're using your ultrasound probes. I can't emphasize enough how knocks, drops, and simple things like if you take your ultrasound machine and the probes are kept at the side, even the kind of power supply cables, if they come under the wheels, they'll get damaged, they'll get crushed, there'll be drag. You'll end up damaging the acoustic insulator element, and then basically you don't get as good a generation. So it's really important. What is also very important is that when you apply a probe to any tissue, so you can see over here the tissue in orange, there's air interface between the probe and the tissue. Now, just remember, air is a massive reflector of sound waves. So when sound waves basically move forwards, if you have air interface in between, then these sound waves are going to reflect back. And because there is a big difference between the density at which sound waves are interacting and entering into air, which has a very low density, the acoustic impedance mismatch, which I'll talk about, causes virtually all reflection. And you're not going to get a good image. You might just get what we call as a dark image or a dropout kind of anechoic image at the back because sound waves aren't actually interacting with tissue. So in order to allow sound waves to interact with tissue and decrease the acoustic impedance, which is generated by air, we use jelly. And jelly is a liquid. And what we know is that jelly, being with a slightly lower acoustic impedance creation, so the density here and the change in sound waves between jelly and the tissue will be much less than the acoustic impedance between air and tissue. So actually that will allow better penetration. And that is the principle with which we use and why we use jelly whilst we're actually interacting with a probe and tissue. Any questions on that? Any questions? So you can write your questions in the message box as well. I'm quite happy to answer that. Now, at the end of the day, when sound waves interact with tissue, they, through the kind of generation of what we call is uh, waves which go back into the probe, return to the machine. And eventually, when they return to the machine basically, through algorithms, interacts with whatever sound waves are returning to produce an image that we see on the screen, which basically produces different amounts of grayscale depending on the tissue with which it's interacting. If it interacts with solid tissue, you're more likely to actually see a tissue-like effect. On the other hand, if you've got air or fluid, you will have different patterns. And often with air, what will happen is you'll really get what we call as artifact, as opposed to the kind of tissue anatomy that you generally see. This is quite an important concept because really, when you're looking at lung with an ultrasound, you're not really looking at the internal structure of the lung as an organ. You're looking at artifact, which is basically like a mirage. It's the interaction of sound waves with air in the lungs, the alveoli, the interstitial fluid, how the sound waves get trapped, reflect back, and those interactions produce patterns. They don't actually look at tissue reflection. Like the liver looks like tissue. With the patterns we see, we generate A and B lines, and eventually it's the interpretation of A and B lines, as well as what I would call as C profile, which eventually gives us a diagnosis of this kind of six pathologies that we want to be confident at diagnosing by the end of this course. Uh, it is it is quite, I would say, easy to learn lung ultrasound once you understand the physics, but it's also really important to kind of understand that when you look at any ultrasound machine generating kind of ultrasound waves, The ultrasound machine assumes that these waves move in one direction and they come back in one direction, and they take a straight line movement towards the organ and they reflect back in a straight line. The ultrasound machine and the probe also assume that these sound waves travel at the same speed, and that when they enter an organ, they'll continue traveling at the same speed and reflect back with a constant speed as well. Now, the real facts are that that's not the case. As I said, differences between the nature of tissue, the different elements of tissue, fat, fluid, the liquid inside tissue, the tissue architecture, you're going to have a lot of different things happening to those sound waves. A really good kind of thing that you'll see is the concept of scattering, and that the sound waves, rather than kind of taking a straight line, hitting tissue and coming back, will scatter. They will enter, they will refract, they will bounce off in the areas of the intestine that you see over here. They get trapped, and really, when they get trapped, the sound waves will cause the tissue to shake, and that is called reverberation artifact, and that is something that we commonly see in the lung. So, whilst the machine makes an assumption that the sound waves will come back and we'll be able to get a good image. The fact is that your ability to be able to keep the probe in a certain way in the right place to be able to get good images is quite key. And I can't emphasize enough how, with all forms of kind of ultrasound imaging, whether that's the brain, so if you put a probe over the skull as opposed to the anterior fontanelle, good luck, you're not going to get good images. Similarly, if you take an ultrasound probe and you put it over a rib, and you don't really get good penetration of sound waves between the rib spaces, you're not going to get very good images. And that is going to be because of reflection. It's going to be because of scattering of the sound waves even before it actually enters into the lung. What we also know is the tissue density changes. So if you look at just the bowel, and I'll talk to you about lung, the tissue in the colon is going to be much thicker uh, than the thin-walled small bowel. In addition, if sound waves have to penetrate and interact with bowel by using the liver as a window, there's going to be a lot of reflection of the liver. So the normal velocity that sound waves would take through liver, because of its high density, will be very different to what it takes through bowel, which is full of fluid, where the lower density might allow faster propagation. Now, that those properties, and a simple example is if you've got fluid, as you can see in the portal sinus over here, it's got a lower density. And because it's got a lower density, sound waves tend not to reflect back. They will pass through without reflection. And if they pass through without reflection and they're not coming back to this probe with a lot of reflection, you're going to get a very anechoic image, a dark image that you can see over here. But if they interact with tissue, which is very cellular, really what you're going to have is the tissue capsule, which is very dense tissue. So a lot of reflection from the liver capsule, giving it a very bright image, and then a lot of interaction trapping within the liver tissue, which then gives you the liver architecture. So in essence, I would say that there's a lot of the properties of sound waves which kind of mean that what the machine assumes doesn't really happen, and those properties need to be understood very carefully. Uh, I think a very important aspect is that sound wave doesn't always take the shortest path back. It may reflect, refract, it may get trapped, and it may take multiple different paths to actually enter tissue. And a very good example of this is the heart. So you can see a probe basically entering here. Now, in an ideal world, this probe just generates sound waves which makes go an impact on tissue, and they should come back. Now, the shortest path that this sound wave takes at this particular point is this path. So naturally, an incident sound wave taking the shortest distance, hitting the epicardium of the heart, the epicardial wall, will interact with it and reflect back, and it will reflect back without losing energy. It'll take a short distance. So actually, the epicardial wall that you see over here, of the actual left ventricular chamber, it's very bright. As the sound waves enter the tissue, they lose energy, they scatter, and they start interacting with tissue which has a different density as compared to the epicardium. So actually, the sound waves pass through, they don't reflect as much, they lose energy, and you get this kind of hypoechoic region. And then suddenly, you've got a heart which is full of blood, Now, we know that the density of blood is much less than the density of tissue. So sound waves will travel slowly here. They'll lose energy, they'll attenuate. So you get this hypoechoic region. But really over here, the sound waves will pass through without any problems. There won't be much reflection at all. And because they pass back without any kind of reflection and increase in their propagation velocity, there is not much reflection at all. And the sound wave basically gives what we call an anechoic image because it's fluid. So fluid tends to give you that anechoic kind of image. Again, you then have the endocardium, which basically is tissue-like, and sound waves suddenly move from a low density to a high density tissue-like structure. There'll be more reflection from this. So at the end of the day, when you actually look at the way sound waves interact with the heart, that's what gives you the epicardial and endocardial brightness of the papillary muscles. But because there's blood which is fluid in the middle, you kind of get a very anechoic kind of an image. Does that make sense? Any questions about that? Any questions? Feel free to unmute yourself and ask me any questions if you want to. Okay. So now we're going to talk about a very, very, very important concept. And this is a concept that I'm not going to move away from until all 17 of you completely understand what frequency, wavelength, and amplitude mean when we talk about an ultrasound wave. Now, I want you to have a look at the image on the right. And if you look at this image on the right, what you'll find is that you have a probe, and that is emitting sound waves at this particular point. And those sound waves basically move in a certain kind of a pattern. Now, the pattern of the sound wave above the baseline is what we call amplitude. And the distance between these sound waves, between each sound wave, is called wavelength. Now, what we know is that if you generate sound waves, you can generate sound waves at a rapid rate. So can you see me clapping at this particular point? So the rate at which I'm clapping, if you all look at me, is basically the frequency. And the time between claps, one clap, second clap, this is basically the wavelength. So this clapping, this is frequency. And the time between two claps is basically the wavelength. Now, the loudness that you hear, this is actually the amplitude. So this is a higher amplitude. This is giving you the loudness. This is a lower amplitude. This is not giving you the loudness. Why is it so important that we understand these? Now, if you look at the way an echo returns, so this is a person clapping, it interacts with a brick wall and it returns back. Now, if he claps very fast, you will get multiple sound waves going very quickly, interacting with the wall and coming back. You get multiple echoes, and they'll be very close together. So, what you might find at that particular situation is that the actual interaction of the sound waves as they go, because there's a very short distance between them, will mean multiple echoes coming back to you. On the other hand, when you have a kind of a lower frequency of sound waves, you'll have fewer echoes coming back to you. Now, naturally, if you have a large number of echoes coming back to you from tissue in a perpendicular way, you're going to get better tissue delineation. You're going to get better tissue interpretation. On the other hand, if you have fewer echoes coming back to you, you're not going to get as good a tissue demarcation because naturally there are fewer echoes which are interacting with tissue. Is there any confusion about this concept? Anybody that is confused? You happy you understand that? Okay. You can say yes if you do. Yep. Now, what happens from our perspective when sound waves are used with a high and a low frequency? Like I said, that if you use a high frequency, you're going to have a large number of echoes emitted. Now, when you have a large number of echoes emitted, the echoes, when they interact with tissue, they're actually going to be closer together. So you're going to have shorter wavelength. On the other hand, if you use a long frequency, you're going to have fewer sound waves produced. And because there are fewer sound waves produced, they're actually going to have more distance between them, which means a long wavelength. Why is this important? Because when these sound waves interact with tissue, like I said, the number of echoes that interact with tissue will be higher with a higher frequency, which will produce much better tissue delineation, a much better image. A lower frequency from our perspective may not produce as good an image. And then a lot of this will also depend upon how sound waves normally interact. Now, if you look at any sound wave moving, what you'll find is that it's not as if they move in a straight line simply like this. There is sound that's going towards tissue and sound waves that are coming back. Now you can see that there's a high density here. There's a high density here as the sound waves move. So again, just high density moving forwards, high density moving forwards. This is called a compression. And really the relaxation of sound waves. It's like a spring. So if you let a spring, if you compress a spring and you let it go, it will go with more energy. On the other hand, if you compress it less, it will go with less energy. But if you just leave a spring compressed, eventually what happens is it compresses and relaxes until it stops. So there is an element of energy transition that's taking place, and we call these compressions and rarefactions. Now, waves in this situation can travel with slightly different frequencies, and how that then interacts with tissue determines really how good your image quality is. Now, what implications does that have for lung and technically for a lot of other tissues? So, this image here delineates this very well. So, assume this is lung tissue that you can see on the right hand side over here. And I'm using a high frequency waveform. So as we said, with a high frequency waveform, you're going to have a large number of echoes that are generated, which are quite close together. Now, as they penetrate into tissue, like I said, because they're close together, they tend to interact with the tissue more. So let's assume this is 1 gram of tissue. So the number of waves interacting with this 1 gram of tissue will be quite high. Now, the number of waves interacting with this 1 gram of tissue being high means that you're going to get more echoes back. And if you get more echoes back, you're going to get a very nice image. But there's just one very big problem with that, is that the more these sound waves interact with the tissue, they lose energy. And when they lose energy, we're kind of in a situation where they cannot then propagate deeper into tissue. So whilst we will get a very good image over here, which will be high quality, if we want to see the deeper parts of tissue, we may not get such good images in the deeper part of tissue to the point where you may even get dropout because the sound waves are just unable to penetrate deeper into tissue. They attenuate completely. So if I really want to see a reasonable depth of tissue, what I might have to do is drop the frequency so that these sound waves lose less energy as they penetrate into tissue. Now, the benefit of using a low frequency then is I can see deeper into that tissue, but actually because these sound waves are wider, they have a longer wavelength between them, their ability to interact with this gram of tissue is going to be less, and there are going to be fewer echoes coming back than as compared to a high frequency probe. So actually, the sharpness and the delineation, the clarity of the image in this entire area that we see over here may not be as good as we would like over here. So how is this relevant? So it's relevant because if this is pleura and I want to see pleura, so this is pleura and the superficial layers, which is quite high in its density as compared to the depth of the lung, which in a term baby, on average, we want to keep at about 4 centimeters. Then really from my perspective, a high frequency probe that interacts with the superficial areas of the lung would be better. Similarly, if I want to see depth in the lung, because I need to see the whole of that area, the geographical footprint of the lung, I might have to accept that there will be a slight compromise on the quality of the image with the pleura, and I can see sliding, but it allows me to see the whole of the lung tissue to be able to get a good idea of the artifact and make a good interpretation of the lung tissue. Okay, now that's very relevant in babies. So, can anybody tell me why that's relevant in babies? Anybody? Feel free to unmute yourself. Has everybody
But
got this? Yeah. Yeah.
can you repeat the question? What exactly you want?
So, my question is that where would you use a high frequency probe in a baby for lung ultrasound, and where would you use a low frequency probe?
high frequency for like extreme preterm يعني more يعني organs more superficial than bigger baby. So bigger baby will use low frequency with the يعني long wave. It will penetrate more like this.
Brilliant, brilliant. So what Nasreen is saying is quite relevant. So from our perspective, we know that a preterm baby's lungs will be much thinner and more superficial. So this is a preterm baby's lungs. So if I want a high quality image, actually by using a high frequency probe, if this is a baby who's 400 grams, this is how thin the lung is, a high frequency probe would be much better because it'll give me a very high quality image with adequate penetration. On the other hand, if I've got a much bigger baby, using a high frequency will result in dissipation, loss of energy, where I can't actually see the whole of the lung. So in that situation, using a lower frequency probe would be much better. Now, by definition, when I talk about the protocol tomorrow, what I will tell you is that we tend to start with a frequency of 8 to 9 in term babies. And in preterm babies, what we normally do is we use frequencies anywhere between 12 and 18 in the literature. Every author kind of has slightly different kind of ways of doing it. And experience says that the more preterm the baby, the higher the frequency. So, if I'm using a 400-gram baby, a probe with a frequency of 15 to 16, which is technically the hockey stick, which has a smaller footprint, would be much better as compared to using a linear probe, which may have a lower frequency. But in adults, say for example, they tend to use the curvilinear probes, which frequencies of 5 to 6, because naturally their lungs are much bigger and you really have to penetrate up to 10 centimeters in an adult. In a term baby for us, 4, maybe 5 max. In preterm babies, we normally say 2.5 to 3. Smaller the baby, you can go down to 2.5 centimeters. So it's really important that you understand that higher frequency waves will have lower amplitude or distance between them. Because of that, they can interact with tissue better. Now, why is that important? So if you have tissue and I have two cells in a tissue over here, because there's a lower amplitude between these waves, you're going to have more waves interacting with these two points within the tissue to be able to tell me that these 2 points are separate. But if the same 2 points are basically kept over here, can you see how it's only one wave that's actually going to interact with them? In fact, it might even get missed to the point where you will not be able to differentiate these 2 points between the tissue. So a low frequency probe will not give you good resolution. A high frequency probe will give you good resolution, but it will be at the compromise of being able to interpret the depth of tissue. Okay? I'm not going to move forwards until I'm absolutely sure that you all understand this. So does everybody understand this? You can type
Yes.
yes. Okay. Say
Yes.
yes. Yeah.
Yes.
Okay. Does anybody not understand this? Is anybody confused? Trust me, uh, if you don't get through this, then not only have I failed, but you will not understand how to do lung ultrasound and you will not be able to image optimize. So I'm going to move forwards, making the assumption that you guys all understand this. Okay. Now, like I said, if you use a low frequency probe, you'll get deeper penetration into tissue, but resolution will be compromised. If you use a high frequency probe, you will get less penetration, but higher resolution of superficial tissue. And this becomes increasingly more important in babies who are born preterm because the lungs are smaller. So in a smaller baby, what I would be using is a higher frequency. In the most preterm babies, I use frequencies as high as 15 to 16. That's as much as my hockey stick probe will allow. I know that some people are using even higher frequencies. I haven't experimented with that, but a probe frequency of about 12 to 15 in preterm babies is good. The more preterm the baby, I would go to a frequency of 15. Normally, most probes will default to a frequency, and like our preterm probe, and I'll show you tomorrow, defaults to 12. So if I'm doing an extremely preterm baby, I will alter the frequency to try and image optimize. On the other hand, for a term baby, where we need depth, I will drop the frequency to about 8, sometimes as low as 7, as you can see in the WhatsApp group today. Naturally, as the frequency goes up, what you find from your perspective is that the actual wavelength, between tissues is less. and with a high frequency, penetration is compromised, as this graph shows. What about probe footprint? Now, this is another very important concept. So just remember that different probes have different maximum frequencies, but they also have different footprints. So when you look at how sound waves emanate from the probes, really, from our perspective, uh, they will take different kind of footprints, and this gives you a nice wide footprint. So I can get a large area of the lung if I was using a curvilinear probe. But the maximum frequency for a curvilinear probe is about 5. So it's not going to really give me a very good superficial image. So if you look at the image here, can you see? I mean, it's very difficult. Is this the pleura? Is this the pleura? Is this the pleura? I mean, likely this is the pleura. It's tricky. On the other hand, using a high frequency probe that's linear gives me a decent footprint, but because I'm using a frequency of 12 in this baby, I'm kind of in a situation where I can see this is the brightest bit. This is the pleura, absolutely no doubt about it. So it's giving me very good tissue delineation. When I look at it, the way tissue is delineated superficially over here is much better. But because I'm using a higher frequency, you can also see that I get a lot of dropout here. I'm not getting this deeper tissue kind of appearance that I would normally get over here. So I might want to use something in between. Now, for an extremely preterm baby, what I would say is that a linear probe will suffice, but you might want to use a hockey stick probe, which can give you even higher frequency. But probably the worst probes to use in neonates are the sector probes. Now, why is sector probes not good? So this is an S5, S6 kind of a sector probe that you use for echocardiography. And the reason why they're not good and I don't recommend them, I would use them if I was desperate, really from my perspective, is because can you see the footprint? So can you see? You can barely see any pleura here. I mean, how am I going to interpret sliding? This is the microscopic bit of pleura that I can see. But more importantly, I'm losing a huge amount of my footprint. It's giving me such a small footprint superficially that actually if I had and I wanted to interpret subpleural consolidations in RDS, I'm barely going to see any. It's going to merge a lot of those images. And actually the B lines, it's going to be pretty tricky because they have to come out like this. So I might get a slightly better image deeper down because the frequency is lower, but I'm not getting much of the pleura and the superficial structures. So in my opinion, a kind of a linear probe or a hockey stick are usually the standard probes that we use because of this footprint. Uh, so again, just my apologies, my mouse is moving too quickly. This kind of exemplifies the different probes that we use, and really the common probes that we use will be the linear probe and or the hockey stick. The hockey stick gives really good frequencies. Our hockey stick gives us up to 16, but a lot of the hockey sticks can give you up to 22 megahertz, and they're used for vascular access as well. But those are the two common probes that we'll use. Just for those of you who do not have a hockey stick or a linear probe, do not worry, because I will teach you how to use curvilinear probes, which usually you can get frequencies of up to 8 on. So, an S9 probe, which is a sector probe, can also be used for the purposes of actually looking at the lung. The only problem that you're going to have, and again, I'm just taking you back to this baby, if you use a sector probe, which is a square probe, which is quite a small footprint, and this is the baby's ribs. Now, a linear probe will give you a large footprint when you use it perpendicularly. So you'll be able to see 3 ribs, 4 intercostal spaces. But if you use a small sector probe, then really from my perspective, you're only going to be able to see 1 rib. It means that you're going to have to take multiple images to be able to get the whole of the lung architecture. Can you imagine how much handling that is? Can you imagine how much ultrasound that's basically putting into a baby's lungs? Now, just be aware there are animal studies that show that you can actually cause pulmonary capillary hemorrhage. So we want to restrict the amount of handling. So actually, if I've got a long linear probe, which gives me a decent, really long footprint, so my linear probe kind of means that I can see everything within one one kind of perpendicular image. And I can see R1, R2 anteriorly, R3, R4 laterally, and R5, R6 at the back. And it's just 3 images that I have to take to be able to see the whole of the lung architecture. So again, that's kind of quite important, and physics has quite an important role to kind of play in how we then kind of want to select our probes. So just having done that, I'm going to talk a little bit about the concept of interaction of sound with tissue. Are there any questions that you'd like to ask me? Any doubts? Am I putting everybody to sleep or is everybody awake?
We are awake.
Brilliant. Okay. Now, like I said, sound waves when they kind of in when you kind of have the transducer sending them into tissue will reflect back. That will produce your image. But I said that sound waves don't move in a straight line because of the nature of tissue. So when they interact with tissue, they will scatter, they will get trapped. When they scatter and they get trapped, really from our perspective, they cause tissue to shake or vibrate. That's called reverberation. Just also be aware that sound waves can kind of get absorbed by tissue. So if you have very dense tissue, it will absorb the sound waves. And if sound waves get absorbed, then you know that as you go deeper down, the more the absorption, really the weaker the sound waves will become. So your image outside here might be much better than your image that goes down here. So you might find that you get a concept of a loss of sound wave architecture or tissue architecture from superficial to deep. Uh, that is also because of attenuation, because of loss of energy as opposed to absorption. So actually understanding this is very important. What is also very important from our perspective is this concept of refraction. So we know that when sound travels with the shortest distance in and out, it will lose the least amount of energy. And if you have high energy sound waves coming back to the transducer, then that energy that comes back to the transducer gives you a much better image reflected by your gain settings. So if you have adequate gain, it means that your sound waves are mostly being reflected perpendicular, and you might have areas of tissue that you want to kind of magnify or see much better. So you might have to alter and move your transducer to be able to do that. Or you might have to change gain settings, which means that it improves the energy of sound wave coming back to you, reduces attenuation. Now, if sound waves refract a lot, then naturally they're not going to be able to reflect back to you. And there is a problem there then that you get refraction, which causes those sound waves again to give you image that is best bright in the center when your probe is perpendicular, as opposed to if your probe is kept at the margin. And a classical example that I will show you is that in the lung, and I want you to look at me, guys. So if this is your probe and you keep your probe at right angles, you are going to get the crispest images. But if your probe is kept laterally, then your sound waves are going to enter, reflect back at abnormal angles, but they're also going to refract more because a transducing probe that's kept laterally is going to have sound waves that are coming in different directions, incident with tissue at different directions. And if they refract more, less of them are going to come back to you straight. And that's going to affect the quality of your images. So you need, and I cannot emphasize, if you want to get good high quality images, you need to keep the baby still. You need to use all the tricks in your armory to make sure that your probe is as perpendicular as possible. Okay. Now, just remember, and again, I want you to look at my chest. If my probe is kept perpendicular, it's easy to do at the anterior part of my chest. Okay. So going back, it's easy to do at the anterior part because it's a flat surface. But when I keep my probe in the lateral part, this is not a flat surface. This is an angulated surface. So to see the right or the left upper lobe of the lung through a lateral margin, keeping it perpendicular is going to be quite tricky. And that's why it's so important. You need to get the nurses to abduct the arms so that you can get your probe completely perpendicular to get the best images. If your probe is not perpendicular, you're not going to get good images, and the refraction will interpret your pleura in different way. You will miss out on B lines. So again, it is very, very important. I cannot emphasize this enough, this concept that you need to keep your probe as perpendicular as possible in relation to the tissue. The most important next concept is that of acoustic impedance. Now, what is acoustic impedance? We know that sound waves, if they go through any tissue which is uniform density, so if they enter the liver, the capsule of the liver, very densely packed, very bright, it'll be very echo bright. You'll have a lot of reflection because it's a smooth surface. But as soon as we enter the liver, which is tissue-like, sound waves will get trapped, They will move at a constant rate through tissue, but the actual difference between the margin, so the density of the liver capsule and the density of liver tissue, it's very different. And because there's a difference in this density, you will have maximum reflection at the liver surface. This also applies to the lung. So assuming that from my perspective, this is lung, then really pleura superficially is quite dense. And then you suddenly have alveoli which are filled with air. So there is a difference in the density with which sound waves will move between air and the pleura. And the higher this difference in density, the more the reflection back. So if you have pleura and air, you'll have maximum reflection at the pleural air interface, which means pleura will appear bright. But the portions behind that may not appear as bright. So pleura tends to be leaner and appear as a bright structure. This difference in density is called acoustic impedance, and it really depends on tissue. Now, a very important concept. So let's assume that you have bone. Yeah. Okay. Now we have skin, you have soft tissue, and then you have ribs, and this is muscle in between. Now, ribs are bone dense, high density. So actually, you have a high density, and the difference in the acoustic impedance when you go from a high density to a pleural, which is medium density, as opposed to air, which is low density, means that there will be high reflection back from the bone. And because of this, actually, sound waves will not be able to enter. And for that reason, what you get is you get dropout behind the ribs. So really, your probe has to be placed in such a way that it can actually get sound waves to move between the ribs to be able to interpret artifact below that. So the difference in acoustic impedance between the ribs and the pleura, as well as the intercostal space in the pleura, means that sound waves penetrate better between bone because bone is a high reflector, and there is a massive difference in the acoustic impedance between the bone tissue interface as opposed to the muscle pleural tissue interface. Okay, the more the acoustic impedance, the higher the reflection back, the better the quality of the image. And this is a beautiful image. So as you can see, so this is a cyst, and this is basically where your probe is kept, and it's kind of emanating sound waves. Now, like I said, you don't have bone over here, you've got tissue. Now, tissue, you have lipid in tissue. So actually, sound waves traveling through lipid and tissue, they're not going to reflect back as much. The velocity is going to be constant. So you get this kind of hypoechoic kind of region over here. And then suddenly they hit muscle, mucosa, you know, that has got much higher density. And there's a difference between the lipid layer and the muscle layer. So naturally, there's going to be high reflectivity back. Because there's high reflectivity back, you can see the cyst wall and it looks bright. But then you enter into tissue versus fluid. Now, the acoustic impedance, the difference between when it enters lipid versus the wall to going into fluid, we know the density of fluid is much lower than that of the cyst wall. So the difference in acoustic impedance is not that high. So this looks less bright, the inner part of the cyst wall. But there is actually no change in density all the way. So there's no change in density. So the acoustic impedance here is constant. So sound waves will now move at a constant propagation velocity. If there's no difference in acoustic impedance, there's going to be very little reflectivity. So these sound waves, some of them will reflect back. The echoes will be weaker. Again, as we go into tissue, we lose energy. So what you find from our perspective is this large anechoic structure, and it gets darker as the sound waves go in. And then the cyst has got exudate. Now, again, the density of exudate will be higher. So there'll be a difference in fluid density and exudate density. So there'll be higher reflection from this, more echoes going back. And really, the sound waves will also gather some energy from the actual exudate in the tissue. The tissue will give the sound waves some energy. So this reflection back means that you can actually see exudate within the actual cyst. The next change in acoustic impedance will occur when it hits the cyst wall. And again, you're going from a low to a high density, high acoustic impedance. So you see the margins of the cyst wall. So this is the concept of acoustic impedance, and it's very important. as we will see. Now, this is just a slide which shows you the different kind of densities, and it's quite interesting. I mean, if you look at bone, it's nearly 2000. If you look at kind of fat, it's much lower. Water, again, fluid, much lower. But from our perspective, again, air is a massive reflector. But what you're looking at is the difference between acoustic impedance. So the difference between air, the density of which is very low, and bone is much higher than the difference between muscle and bone. So it's 900 here. Over here, it's massive. So it's really important from our perspective to understand that the difference in the acoustic impedance is what increases reflectivity and produces the brightness of the image. Okay, we've talked about reflection image generation. So how does this apply to lung ultrasound? So I'm going to skip these slides very quickly because I just want to show you how it applies to lung ultrasound. So when we look at a lung ultrasound image, like I said to you, there is skin, subcutaneous tissue. These white areas that you see here are the ribs. These are ribs. These are ribs. Now, if you look at ribs from our perspective, that's a rib there. So let me try and use something else rather than the pen. I don't want to use the marker. I do not want to draw. Spotlight. So this white area here, these are ribs, and this is an intercostal space. So I can see one, two, three, a fourth rib, about four ribs, and I can see one, two, three, four intercostal spaces. Now, like I said to you, reflectivity and difference in acoustic impedance means there'll be maximum reflection across the rib, which means you're going to get this area of darkness behind the rib. This is dropout. And this basically is an area that you're not going to be able to get tissue interpretation of. But between ribs, you've got muscle, and then you've got this dense, bright area of pleura. So the acoustic impedance difference means that reflection will be maximum at the level of the pleura. This reflection at the level of the pleura produces a bright pleura. And if you look at my hands, we know that there is parietal and visceral pleura. So if there's parietal and visceral pleura that moves on itself, you get this shimmering kind of effect. And this shimmering is sliding. So you can see sliding here. How do we define sliding? So you can see these small areas. These are called comet tails that you see. They're moving from side to side. The lung is moving from side to side. So this pleural movement is called sliding. And if you've got sliding, then from our perspective, you cannot have an pneumothorax. Okay. Any questions about that? Any doubts before we go back? So we've already talked about these properties. We've talked about attenuation. Attenuation basically means that as an acoustic wave enters tissue, it gets absorbed, it loses energy, and it gets weaker. So similarly, what I would say is that if you kind of had to go through bone, naturally there's going to be 100% reflection, massive attenuation. On the other hand, if you have to go through kind of soft tissue, lipid-laden soft tissue, there's going to be less attenuation. So eventually, if you've got a lipid layer with pleura, there's no bone in between. So actually, because there's less attenuation of sound waves, they interact well with the pleura and the pleura appears bright. But you can't see the areas of pleura under the ribs because the rib basically is causing 100% reflection. It's virtually absorbing any sound waves that go in and attenuating any that move behind it. So you can't see any pleura beneath it. A little bit for kind of more reading, but in essence, for a preterm baby, we use higher frequencies. You need frequencies which start between 12 and 18. For a near-term baby who's 34 weeks, I might start with a frequency of about 9. For babies who are more term, it's kind of 8. I might even go as low as 7. General standard is 8 to 9. For extremely preterm babies, much higher. Uh, it is important to understand that we have attenuation behind bones. So we'll have what we call as dropout or rib artifact, which means that you can't interpret tissue behind it. It is very important, and I'll explain why. Just remember when you when you image a baby on the back, you have scapula. It's massive. Now, if you try to image through the scapula, you get zero. If you put your probe in the midline, you get the vertebral column, you get zero. So imaging the back is not easy. And the reason why it's not easy, again, is because the baby arches. The more he arches, the more you press, you cause more pain, your image quality actually deteriorates. So when you hold the probe, it should be very light. It should be in contact. So I'm just dropping my phone, as you can see in the hand over here. There should be contact. There shouldn't be pressure, because the more pressure you put, the more the baby will arch his back. The more he arches his back, the you know the smaller the spaces between the ribs, the more scapular kind of tightening, scapula coming medially, it'll just compromise your image. Uh, Often, if you have kind of a lot of bone interfering with your imaging, you just get black information-free area. Eventually, when you scan, it's really important to be able to get between the bony spaces to be able to do that. Uh, Again, just the concept of frequency and amplitude. So this is just an example of using a probe in an adult to see the lung, and this is one intercostal space. This is basically a kind of a longitudinal view. And really, again, what I'm going to highlight is the fact that on this particular view, you can see much more, much better. So when you look at this particular view, you can see the whole of the lung right down to the bottom. But because we're using a convex probe, we're kind of losing out a little bit with this kind of high frequency on the depth here. It's not as well delineated. Can you see how you can't delineate tissue? But because you're using a low frequency here, you can actually see a much better tissue appearance. There's a big problem here, in that because you're using a low frequency probe, which is not appropriate because you want to see the superficial part of the lung, which is what you're seeing here, these B lines that you see, they're completely being missed. So it is very important that you use the correct frequency to be able to image the lung. I would say that if you're trying to image the superficial part of the lung, and a simple example that I'll give you is if I want to look at pleura, it's not unusual for me to reduce the depth to kind of focus on pleura, and machines will have a focus function. Some machines autofocus, like if you use the new GEs, you don't have a focus function. So you might have to focus more on the pleura. But in some situations, if you've kind of got an autofocus like a GE machine, the only way that you can actually see the pleura is by increasing the frequency. And that basically makes the pleura more well delineated. If you want to see the depth of tissue, as you can see over here, you're going to drop the frequency. Okay. Any questions? We've talked about absorption. Just a little bit about specular and diffuse reflection. Now, just remember, as I said to you, that if your probe is perpendicular, and in particular if the tissue is linear, then really that is going to give you the best reflection back. It's going to give you a sharp, bright image because sound waves travel with the least distance and reflect back with the least distance. More importantly, there is what I would call is no scattering. But if you have irregular tissue, and a classical example that I'll give you is if you've got an ammonia with breakdown, the margins of that pleura, which is kind of moth-eaten, is going to be quite irregular. You're going to get reflection, but it's actually going to give you a lot of attenuated sound waves, which have kind of refracted back. Sound waves that go in will interact with tissue in a different way. So normal pleura with A lines, the pleura appears bright and you get reverberation artifact. But if you've got a pneumonia with atelectasis, then you might find that actually you don't see a bright pleura. If there's complete atelectasis, you don't see the pleura at all. And what you see is liver-like tissue, as opposed to kind of seeing reverberation artifact. So diffuse reflection commonly occurs in situations where you've got bad consolidation pneumonia. Diffuse reflection will also take place in liver, where you have tissue. But in the lung, where you've got pleura, alveolar, interstitial, air interface, really the pleura tends to appear echo-bright mainly because it's specular nature of reflection as opposed to scattered nature of deflection. Uh, and again, just an example. So speckled reflection in the lung tends to cause reflection at the level of the pleura. The interaction of sound waves when they enter the lung, it's not tissue that you're seeing. You're seeing the interaction of ultrasound waves with the alveolar air, with the interstitial kind of fluid, and that ratio governs patterns. On the other hand, if you look at the brain and the structure, it's very tissue-like, but it's got very irregular kind of a structure. So pleura will appear echo-bright, but when you look at the brain, you actually can see sulci, gyri, you can see a lot of tissue, you can see a lot of the fineness of the tissue. And all of that is because of this concept of diffuse reflection, because the echoes that are produced back are really scattered. So again, what's happening here is scattering, which is giving you the anatomical kind of appearance. So the brain, we're actually looking at anatomy. We're not looking at artifact, though you can sometimes see artifact as well. Again, we've talked about the importance of perpendicular probes. So if you have non-perpendicular probes, your image will be generated very poorly because the sound waves will be incident, take long distances, they will reflect in odd directions, they will also refract when they go into tissue. You will lose energy between the sound, ultrasound waves and the tissue as they penetrate because they're having to travel a longer distance. So for all practical purposes, try and keep your probe as perpendicular as possible. You can have, and I'm not going to cover angle of inclination. We've discussed this, why we tend to use, and this is just a really good example. So your probe here is a linear probe which is kept perpendicular. Now, just remember that even a linear probe has a kind of a geographical footprint. It will generate ultrasound waves because of the piezoelectric crystals in multiple different directions. But really, what we want to see when we use a linear probe is we want to be able to see the ribs and the intercostal space. Now, by definition, and I will teach you, our protocol is that we need to be seeing at least two ribs and three intercostal spaces. With a good linear probe, I would say that you want to probably see at least three ribs, four intercostal spaces. Now, we divide the lung into upper and lower regions based on a line that travels through the nipples. So if you have 12 ribs, you're really talking about three images anteriorly, three images laterally, and three images posteriorly. With an extended view, you can get the whole lung in. And in the Philips sonocyte and in the GE, you've got an extended view, which means I can just literally use one footprint to see the entire lung in the majority of babies. Uh, Again, if I need a higher frequency, I might have to use a hockey stick. Now, if you are not perpendicular and you are in a situation where you tend to keep the probe oblique, can you see how blurred this pleural line looks on the right? It's because the probe is not kept perpendicular, but you have quite a differential kind of difference between how the tissues are being interpreted as well. So it is really important that when you examine, you keep your probe as perpendicular as possible. Normal lungs, pleura is echo-bright. In a baby, it's about zero point 0.5 to 1 millimeter. Now, classically, from our perspective, aerated lung gives you A lines, wet lungs give you B lines, and that's going to be the next thing that we discuss. Any questions? Any questions?
No.
Okay, so what is normal lung? So this is normal lung. Okay, this is an image of lung where you can see ribs. So you can see I can count one, two, three, four. Behind the ribs, I've got this dropout that I see, which is basically rib artifact. Ultrasound waves can't penetrate. So they will penetrate between the ribs. They will interact with pleura that looks bright. And as I told you, the pleura basically moves, it slides. You can see beautiful sliding here. Can you see these small areas, these small triangles that you see under the pleura? These are comet tails. I'll explain what they are. But you do not have any of these. These are B lines. Now, B lines occur when you have fluid in the lung. So at birth, really, you're going to have this kind of appearance because you've got fluid in the lung and the alveoli. Now, if there's fluid in the lung and the alveoli, you're going to have a huge amount of reflection back. But we know that air, from our perspective, uh, is 100% reflector. So why do we get A lines? Why do we get this appearance? Because really, if you have lungs that are full of air, the ultrasound wave should reflect back and you should just get a dark image. So really, the reason we get A lines is because of the concept of reverberation artifact. Now, before I talk about reverberation artifact, what I would like to talk about is how you recognize that you're in the right place. So if you apply any probe to the chest wall, you always, and I'm going to teach you, there are two ways to scan. There's perpendicular scanning, and there is scanning of each individual intercostal space. And we're going to use a standardized terminology for that. But when you do perpendicular scanning, really you are able to see a rib, you're able to see the bright pleura in between, and you're able to see artifact below that. Now, this concept of identifying the ribs with the pleura in between is called the batwing sign. And this is crucial. And I'll explain why by the last image I show you today. So when I look at the batwing sign, this is the head of the bat, these are the wings. So actually these ribs represent the wings of the bat, and this pleural margin that you see here is the head. Okay. So again, just this is the wings and this is the head. And with the eye of faith, it looks like a bat. Does it look like a bat? Does it look like a bat? What do we think?
Not so
Maybe
much.
a bit.
Yeah, personally, I'm not convinced. Do you know why it's called the batwing sign? Anybody? Anybody? Why is it called the batwing sign? Because it doesn't look like a bat. Wing, head, doesn't look like a bat. So it's basically given the terminology batwing sign because bats use ultrasonic waves to communicate. Uh, in essence, the author who coined this basically used this as a pseudonym to kind of explain. Now, why is this important? Because we know that we need to see 12 intercostal spaces on the right and 12 intercostal spaces on the left if you look at my chest. Now, just remember that below those intercostal spaces, there is liver on the right, there's spleen and stomach on the left. Now, just remember that these tissues and fluid in the stomach can give you a B profile. If you have air in the stomach, again, what I'm saying to you is that sound waves interacting with the stomach are going from soft tissue to air. There's going to be reflectivity and there's going to be reverberation of the stomach wall. So you might actually get a structure on the left that looks like the lung. Now, if that looks like the lung and there's no sliding, you might think there's an pneumothorax and you might end up puncturing lung, and you don't want to do that. So puncturing stomach as opposed to lung. You need to be sure that what you're identifying is the lung. And the only way to do that is to ensure that you can see a batwing appearance, which is basically defined as ribs with pleural sliding. If you cannot see the rib artifacts with pleural sliding, then you're probably quite low. And a classical example is one that I will share with you today. I've already shared it with the group, but it just shows how easily a person can actually get confused. Uh, okay. Uh, Now, besides the batwing sign, we need to understand what horizontal reverberation artifact is. So just again, with this is skin, subcutaneous tissue. These are ribs. This is muscle. And this area here that you see in blue, this is basically pleura. So when you kind of look at how sound waves interact, they will come in, they're generated, they will interact with skin, superficial tissue, muscle, intercostal space, and the ribs. They will also interact with deeper tissue as they go in. Now, naturally, you'll have reflection back, a large amount of reflection back from the bones, with virtually nothing coming in this region, which is the tissue behind the ribs. But a lot of kind of sound waves coming and interacting with tissue in the soft tissue areas. So this causes dropout. And when you have dropout, basically what you get is a bright rib margin and a bright pleural margin. And this is what you call the batwing appearance. But more importantly, from our perspective, the pleura has sound waves getting trapped. So the pleura has a high amount of sound waves interacting with it. And then there's tissue beneath it. So what happens is that when sound waves get trapped between the pleura and the tissue, they cause the pleura to shake. This is called horizontal reverberation. Now, when there's horizontal reverberation, this is also going to produce sound waves. And these sound waves are going to interact with alveolar tissue. And if there's air, no fluid, then they interact in a horizontal kind of a way where the sound waves are trapped in between. And this gives you what we classically call is as A lines. These are horizontal reverberation artifacts. So step one, you identify the batwing sign that you can see over here. Once you know you're looking at that, then you're looking to see whether there's an A profile. If it's aerated lung, you're going to get horizontal reverberation artifact. So horizontal reverberation artifact with pleural sliding, after you've identified the batwing sign, basically indicates that you're dealing with normal lung. So this is normal lung. Ribs, so again, just batwing sign, batwing sign, batwing sign. So this is all lung. This is a generous footprint. One, two, three, four, nearly five ribs. One, two, three, four intercostal spaces. And really, from my perspective, I've got pleura. It's sliding. It's moving side to side. I can see these small triangles at the bottom. They move from side to side. So there's clear sliding. Now the pleura, the sound waves getting trapped here. The pleura shaking means that you get further trapping sound waves here. And this horizontal nature of lines is basically what we call as reverberation artifact. Now, you remember I told you as sound waves penetrate, they become weaker because they interact with the alveolar tissue. So because they interact with the alveolar tissue, you can see how the A lines get attenuated. They become less dense as we move in. In well-aerated lung, you might find that actually the density doesn't actually attenuate. If lung is less well aerated, you might find that there's further attenuation as you move in. So this is aerated lung. And if you can see sliding with aerated lung, R1 to R6 on the right, L1 to L6 on the left in a baby who's got no respiratory distress, that's normal. So this is how you identify normal aerated lung. The problem for us is when babies are born, they're not born with normal aerated lung. They have problem. I'm just going to skip the slide because we've discussed it. They have problems which we call our B lines. Just this is just another example of what A lines actually look like. Now, the reason I want to show you this before I move to B lines is, can you see the difference between probe use? So when I talk about using a probe over here, I'm using a linear probe, and if you look at the footprint, it's massive. I can see such a large area of the lung. I can see the pleura clearly sliding. This is the whole pleura of the right anterior region. And I'm using a linear probe with a large footprint. On the other hand, if I use, again, this is just another, it's a linear probe that we're using in an adult. But if I start using a sector probe, as you can see over here, can you see how little pleura I see? Now, can you see how difficult it is to see sliding in this? You're still seeing a lines, which is reverberation artifact. Now, in an adult, obviously, when you use a probe, and I think they're using quite a high frequency for this adult, you basically get attenuation of sound waves. And because of the attenuation of sound waves, these A lines become less dense as you move in. Uh, by using the right frequency and the right footprint, can you see how much better A waves, A lines are over here? This is an optimal image. If I use the same image here, it's not so good. It's still aerated lung. Now you have to clinically correlate. Again, if this is a baby where you're using a sector probe and you can see this in all regions with pleural sliding, I can interpret pleural sliding over here. And this is also normal. So you can use a sector probe to be able to do a lung ultrasound. Okay. Again, what is reverberation artifact? So basically, sound waves interacting, causing the pleura to shake because of the way they interact. But because we have tissue in between, alveolar interaction, these sound waves get attenuated and A lines basically get lighter as you move in. If you have well aerated lungs, that might not be the case. Okay. Now, B lines, on the other hand, reflect fluid in the interstitial space. And really, the reason we have B lines is because of what we call our tetrahedrons. Now, when you have fluid in the lung, really what happens is alveoli are full of air. But when you have fluid in the lung, you have fluid molecules, and they tend to arrange in this geometrical appearance of a tetrahedron. So when sound waves go into them, like I said, with the alveoli, they interact and they cause horizontal reverberation artifacts. But with fluid, you've got this arrangement. And look, my art is terrible. With time, you'll basically be able to understand that Dr. Sharma can't draw. I'm really sorry. But this is the way tetrahedrons are arranged. Now, when a sound wave gets in, it basically gets stuck and it can't get out. Now, if it gets stuck and it can't get out, and it gets stuck and it can't get out, then really what you get is you get, instead of horizontal, you get these vertical reverberation artifacts. And these vertical reverberation artifacts that you see are called B lines. The more the fluid, the higher the number of B lines, to the point where if fluid becomes so much that you have fluid in this pattern, it will coalesce and eventually you'll get columns of B lines. If you get fluid in the alveoli and fluid in the interstitial space, then there's actually nowhere. The fluid, like I said, will basically mean that sound waves penetrate through a uniformly dense fluid, which produces uniform reflection. You get what we call as white lung or alveolar interstitial edema. And I will cover some of that tomorrow. At the end of the day, this is basically how B lines are generated. So again, I told you, you're going to have tetrahedrons in this region. And these tetrahedrons, they arrange themselves vertically. So instead of getting vertical reverberation artifacts, instead of getting horizontal reverberation artifacts, you get vertical reverberation artifacts, and they organize themselves as linear lines. Now, it's just really, really important for you to understand that B lines, by definition, should extend all the way from the pleural margin to the distal lung. They do not attenuate. Now, if you have a lot of fluid, the more fluid you have, the higher the number of tetrahedrons that you're going to have. So a simple example that I'll give you going back to the last image is, and I'm going to draw and you're going to find out that I can't draw for shit. Sorry, excuse my language. So sound wave strapped, sound wave strapped, sound wave strapped. The more you have in terms of these tetrahedrons, the thicker the lines, the larger the number of lines. And really, once you have more than 3 B lines per intercostal space, that becomes abnormal. So these columns that you see over here, they become larger, 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 and eventually they merge. And if you have fluid in the alveoli, then you get this white out appearance because you can't differentiate the white lung. And can you see this? So instead of having linear B lines, and I'm going to show you lots of examples of them, you kind of got a white appearance because there's a lot of interstitial fluid. There's just fluid trapped within the alveoli as well as within the tetrahedrons, which you can't differentiate. These are thin, uniform B lines. So there's not a lot of fluid in this lung. There is fluid, and it's abnormal because you have more than 3 B lines. So there is interstitial edema here. And a classical example that I'll give you is transient tachypnea, a smooth pleural line with interstitial fluid that's gradually getting better. Now, gradually what will happen is this fluid will get resorbed and these B lines will get converted into aerated lung, which typically means that the alveolar interstitial kind of appearance of fluid has resorbed. So eventually, in a baby with TTN, if you have lungs like this at birth, which are massive amounts of B lines with merged B lines, there are no A lines, so there's no aeration here. And after a few hours, it becomes like this. You get pleural sliding with horizontal reverberation artifact. Baby's respiratory distress is settled. There's no evidence of consolidation, as you can see over here. Then really what we're talking about is TTN as a diagnosis. Now, you're using ultrasound, which you can do in 90 seconds without radiation, with minimal handling in these babies, without having to move them a lot. There's so many advantages of being able to use ultrasound. I can do serial ultrasound. Now, to maybe make a diagnosis of pneumothorax in a baby with TTN who's getting worse, I'm going to do an X-ray now. I might end up repeating another X-ray. Then I'm putting a drain in. I'm repeating another X-ray. Then I want to see the drain position if it's too far. So I might end up exposing this baby to 4 or 5 X-rays to make the diagnosis. I can do serial lung ultrasounds and make that diagnosis without exposing the baby to handling and a lot of radiation. Now, you need to know, and I'm going to end by saying what the difference is between A, B lines, and comet tails. So if, for example, you're in a situation where the fluid accumulates in such a way that you don't have much fluid, you are going to have fewer tetrahedrons. Now, if you have fewer tetrahedrons and they are arranged near the pleural margin, which is how fluid tends to accumulate in the interstitial space, then what will happen is you're not going to get a large number of trapped kind of sound waves. So if you have only one here and it's very close to the pleural margin, but you have aerated lung below it, then eventually what you're going to have is you're going to have reverberation artifact that's vertical over here, but because there's air below that, you're going to get A lines over here. So if you get a small B line like appearance, it's usually triangular, which doesn't extend all the way down, then by definition, this is called a comet tail. It reflects a very small amount of fluid. It is normal and can be seen in babies for extended periods of time. It does not indicate alveolar interstitial edema. Its pathophysiology is similar, but really what it reflects is a B line that is attenuated. So instead of extending all the way down, as you can see in this image, a beeline extends all the way down, it will finish here because you don't have enough fluid. You don't have enough tetrahedrons extending all the way down to trap fluids to produce the vertical artifact. Why is it so important? The reason it's so important is because if you can see comet tails, you can really see pleural sliding. Now, this is just an example that I'll show you. You can see beelines extending all the way to the bottom over here. This is a comet tail. Appears, disappears with the pleural margin. But if you can see it, you can see pleural sliding. Now, if you can see pleural sliding and a comet tail, you can't have a pneumothorax. It excludes a pneumothorax. It's the easiest way to exclude a pneumothorax. Now, this is classical. This is well aerated lung that you see over here on the right-hand side. Pleura, horizontal reverberation artifact or A lines. This is wet lung, pleura, B lines, coalesced B lines. It's much wetter on the left as compared to the right. And then really from our perspective, what you're seeing over here is pleura. This is a very magnified portion of an adult lung, which basically shows a comet tail. And from our perspective, if you can see a comet tail, if you can see sliding, as you can see in all three of these images, you cannot have a pneumothorax. Any questions?
No.
Last thing that
So just,
yeah,
just one technical question.
yes, please.
So all the 12 images, they are the cine loops, not static images.
All?
All those images are not the static images, they are videos, small
Yeah.
videos, right?
By definition, we never do static images with lung. The only place where I
Okay,
would do a static image is if I'm doing M mode. It is like echo. We always take loops. If you don't take loops, how will you say sliding is there or not? So medico legally, if I'm doing a lung ultrasound and I have a pneumothorax, now technically, if I just take a static image, I can't see sliding. So how do I prove there's pneumothorax? You get what I'm saying? So these are all
right.
clips. So what you're seeing on the right-hand side over here, again, just by the protocol, we need to see step one, the batwing sign. So I can see ribs. I can see a nice batwing sign. Nice batwing sign. Now, once I've seen the batwing sign, I know I'm in the right position. This is basically the left lateral L3-4 position. And once I've identified that, the standard protocol is what we call pleura ABCDE. So I'm going to see if there's pleura. I can see pleura, nice, crisp, continuous, sharp. I can see sliding from side to side. I can see these small comet tails coming in. There's actually no B lines here. There is A line artifact which gets attenuated as we move down. This is well aerated lung. Okay. Now, why is it important to identify the batwing sign? Because if you don't identify the batwing sign, then really from our perspective, just remember, this is lung, this is the batwing sign. There's no batwing sign over here. But really from my perspective, if there is consolidation of this area, consolidation will look exactly like this. It will look tissue-like. But this is not consolidation. This is most probably spleen on the left side because you have no ribs. There's no rib margin there. So it's very important that you know where your anatomy is, and the way to identify that is by using the batwing sign. Easily seen over here. Nice, well aerated lung. Okay. I'm not covering consolidation today. I will be covering it tomorrow. Any questions? That's it. Any
No.
questions? Are you happy that you understand A lines, B lines, and comet tails? Any questions about that?
No, it's clear.
Any doubts? Anybody else? Any questions you want to ask me? Any questions about the course in general? Anything outside of this session? Okay, any questions, you can WhatsApp me. I'm going to share a few images as a test just to see what you guys think. But thank you for your patience. I'm really grateful. Tomorrow, what we'll be doing is talking a little bit about the actual process of performing lung ultrasound. So that will be machine, the protocol, and a step-by-step approach. And I'm also going to cover the C profile. I'm going to talk a little bit. The next session after that will cover standard lung nomenclature. But tomorrow we're going to cover how we do lung ultrasound, the machine, knobology, and the protocol. Thank you very much. God bless you all, and I'm grateful.
Thank you, sir.